introduce Gary Siskin, who has already been lauded by Doug, but I'll take this opportunity to also let you know that Gary is the chairman and professor of radiology at Albany Medical Center in New York, and Gary has, as Doug alluded to, really at the vanguard of this whole CCSVI movement, and the one who's really been able to get it together enough to perform randomized trials, and as mentioned, has funding from the MS Society in Canada to treat patients at Albany from Canada. And he is, just so you know, next year going to be program chair of this meeting, SIR. And so this is a very, very, very busy time for him, as it is for our other speakers who are attending this meeting. So I think we give him an extra shout out for spending this time, this valuable time with us here tonight. We're all set now?
Yeah. Thanks, Mike. Thank you, Sharon, for setting everything up, and thanks for everybody for braving the rain and coming out tonight. So let me kind of take you through a research update. It was kind of a broad topic that Sharon gave me to speak on, and you know, it's impossible to cover everything in just a couple of minutes, so I just figured I would talk a little bit about stuff that's happened over the past year. And we're going to focus a little bit on ultrasound, on MR venography, on catheter-based venography, and just some stuff on outcomes after treatment. Let's start with ultrasound, and I think our neurologists here have brought this up. And the bottom line is that it's safe to say there is a lot of controversy about the utility of ultrasound in the non-invasive diagnosis of CCSVI. I think that's a fair statement that probably everybody could agree with. I think that some people think that ultrasound is a great screening tool for CCSVI. I think obviously the leading person in that area is Dr. Zamboni. As you know, he established 5 criteria which he used to diagnose CCSVI in ultrasound, be it reflux in the internal jugular and vertebral veins, reflux in the deep cerebral veins, an internal jugular vein stenosis, or other kind of abnormalities, what we call grayscale abnormalities on regular ultrasound exams, the absence of flow in the internal jugular vein, and then there's the positional changes in the area of the internal jugular vein when you go from an upright to kind of a supine or laying down position. And as was previously mentioned before, he found that patients with at least 2 out of 5 of those criteria being positive always had MS. Now, the one basic thing I've learned as a physician is nothing in medicine is always. There's no never and there's no always. So immediately it makes you think, but there has been others who've agreed with the utility of ultrasound in diagnosing CCSVI, and there are at least 4 papers that have been out that have at least implied that based on ultrasound, there's an increased incidence of CCSVI in MS patients. So that's kind of on the positive side. And by jumping off of that, there have been papers that have used ultrasound to potentially identify risk factors for CCSVI. And the Buffalo group has really been kind of at the forefront of that. And what they did was we call a post hoc, or kind of an after-the-study analysis of the original work that they did with ultrasound. And what they did was they looked at 250 patients or so who didn't have any known neurologic pathology. And all the patients were questioned about various demographic stuff and background and presence of other diseases and risk factors for vascular disease and environmental stuff, and just trying to kind of get a sense of who these people are and how to correlate all of that with the ultrasound findings. All of those patients underwent the kind of prototypical Doppler exam of the internal jugular and vertebral veins, and about a quarter of the patients were diagnosed with CCSVI based on having 2 out of 5 positive criteria. And what these investigators first looked at were all the risk factors that were typically associated with lower extremity venous insufficiency, just like Dr. Arslan talked about before, thinking, well, you know, we know about venous disease in other parts of the body, so maybe these risk factors correlate. So they looked at things like older age and family history and female gender and pregnancies and stuff like that, and actually none of those were associated with CCSVI, 0. Instead, what they found was that the presence of a positive ultrasound examination for CCSVI was associated with things like heart disease, the presence of a heart murmur, the incidence of infectious mono or chronic Epstein-Barr virus infection, a history of irritable bowel syndrome. That was significantly associated with the findings on ultrasound. There was a trend towards smoking and the use of fish oil as a nutritional supplement as being possibly associated or as a risk factor for CCSVI. And then they found a trend towards either the use of dietary supplements or the use of ginkgo being potentially protective for CCSVI. So again, this is a research update. It's kind of just talking a little bit about stuff that's come out about this topic over the past year. Now, on the other side of that, there's the comments that ultrasound may not be a great screening test for CCSVI. And if you see on this slide, there's a lot more people who think that this is the case than who come out actually in support of ultrasound for CCSVI. And it really makes you think, you know, so many people are saying something, maybe they're not wrong. Even Marian Simca, who's really at the forefront of some of this over in Europe, what he presented at the ISNBD meeting just a couple of weeks ago was his work looking at 41, not just 5, 41 different ultrasound parameters, and he found that some were maybe modestly associated with an increased prevalence of abnormalities in the veins, but he was actually unable, with all of that information, he was unable to create a reliable set of criteria. And his conclusion was that a lot more research is needed to improve the diagnostic accuracy of ultrasound for CCSVI. Again, really questioning the role of ultrasound. I think that some of my frustration with this has been that none of those studies that looked at ultrasound then went on to compare the ultrasound findings with venography to see exactly what the story is and why these discrepant findings exist. And you know, I'm taken aback a little bit by people who come out and say, well, if we can't diagnose it with this particular ultrasound examination, then the whole thing must not exist. And I think that that's just a little bit of a leap, and I think all it implies to me is that there's more work to be done. So what we did was, we did a retrospective evaluation. We just presented this data a couple of days ago at our meeting. And what we did was we did a retrospective evaluation of over 400 patients who underwent venography and endovascular treatment for CCSVI over the course of 8 months. And what we did was we found 310 of those patients had undergone ultrasound within 48 hours of venography. And what we did was we looked at the ultrasound and we said, we know people are talking about, you know, the transcranial portion of the ultrasound exam and deciding whether or not that makes sense to do in patients. And so we looked at it a couple of different ways. We looked at 2 out of 5 criteria as being positive. Then we excluded the transcranial Doppler and looked at 2 out of 4 criteria. And then in turn, we compared all of that data with the presence of what we call a 50% narrowing in the vein. Now, I will tell you from our standpoint as interventionalists, that number isn't really a hard number. There are many people that we see that have more significant stenoses, and many people that we see in other vascular areas that actually have, you know, much milder disease, but still have symptoms that seem to reflect a venous abnormality. So we looked at a 50% stenosis really because that's what Dr. Zamboni did. And we figured we wanted to kind of compare apples to apples. And then we also looked at comparing this with what we consider to be a treatable abnormality, meaning an abnormal flow, maybe the presence of reflux, maybe abnormal looking valves, all the things that people who are engaged in this are using to define being a positive examination. So we looked at all of those things. And what we showed was that ultrasound, using those described criteria by Zamboni, really doesn't accurately predict the findings on venography. And so, you know, we created these fancy charts and graphs, but you know, I think what your eye should go to is the false negative rate. All right, so in other words, what we actually found with ultrasound is that we found patients who did have a positive ultrasound, and comparing even just a 50% stenosis with findings on ultrasound. But we also found that, you know, over 3/4 of the patients had negative ultrasounds and actually had that problem on venography. So I just don't think that necessarily answers your question. But what we found was that ultrasound, I think as it's being performed or being, you know, talked about how to perform, it really isn't an adequate diagnostic test. So I'm not surprised that all those people, you know, reported negative examinations with ultrasound. Even when we look at a treatable abnormality, the false negative rate was even higher. So I think that that really confirmed our intuitive sense that ultrasound just flat out doesn't accurately predict the findings on venography and is therefore not a useful diagnostic test. And actually we no longer get ultrasounds on patients because we've just seen them miss too many treatable abnormalities. And our sense right now is that venography really is the gold standard for diagnosing CCSVI, and we're just not at the point yet where we've perfected the best way to non-invasively diagnose this problem. So that brings us to MRV. A lot of people have been turning to magnetic resonance venography as a potential diagnostic test for CCSVI. And I'm sorry I'm feeling worse, I've been talking all over the last couple of days. But you know, there are some people who are out there saying that MRV is an effective screening test for CCSVI. And a lot of that is coming out from Dr. Hackey, whose name is well known probably by everybody in this room. And he, is an MR physicist who does quite a lot of work, and he looked at 200 MS patients who were evaluated with kind of a high-strength MRI. And what he did was he injected some dye, and he was able to look at the venous blood flow. And what he found was that 2/3 of patients had some type of structural abnormality of the internal jugular vein, meaning a stenosis or a blockage in one or both veins, as well as atresia, which is more like narrowing or just poorly formed veins. And he also detected, using certain flow studies on the MRI study, that there was abnormal flow detected in that population. So his conclusion was that MRV is a great thing to do. The problem is that not everyone agrees with that. And so the Buffalo group has come out, fairly vigorously against the use of MRV. And their feeling is that ultrasound is really better than MRV. So you can see we're going around in circles here, all right? And so the Buffalo group did a prospective study of 150 patients with MS. They compared them to 63 healthy patients, all of whom participated in that original study. All of those patients underwent a Doppler ultrasound and an MRI, and only the MS patients underwent an MRV with dye, because their IRB, or their research board, felt that there really wasn't an indication to give dye to the healthy patients. So again, there's a little bit of stuff lacking in that study, but what the study found was that MS patients had a greater incidence of abnormalities than the healthy patients, and also that patients with progressive forms of MS had a greater incidence of problems than patients with non-progressive MS. All right, so that's what they found. On MRV, they found that there were no significant differences in flow, but that more abnormalities were found in patients with progressive MS than non-progressive MS, and that MS patients who had some intraluminal problems, meaning problems inside the vein, had more collateral vessels, meaning alternative ways for blood to leave the central nervous system, than patients who didn't have abnormalities. So they kind of concluded that MRV really had a limited value for detecting the extracranial venous problems, and that, however, it was a bit more sensitive for demonstrating collateral vessels. So they like ultrasound on one part, MRV on another part, and they actually have since come out and said, well, maybe they're best when they use them together. And so they said that's kind of their plan. They looked at, again, a bunch of MS patients, a bunch of healthy controls, and they found that specificity became much higher when the results of the ultrasound and the MRV were combined. I take all of that personally as still feeling like we really don't have a great non-invasive test. And it all comes back to what was discussed just a couple of minutes ago, that this is frustrating. It's frustrating for people who want to find answers to, can we detect an abnormality? And we're really kind of running around, unsure if MRV is right, if ultrasound is right, or if we should, and those of us who are involved in looking at this and treating patients, do feel fairly confident that venography is showing an abnormality. We just can't really figure out a way to diagnose it non-invasively. So then we move on to venography, and we say, okay, there have been some studies. One of them has been looking at the prevalence. So how often is CCSVI occurring in this population? And for that, we kind of turn back to Marian Simka's work, who looked at almost 600 patients who underwent venography of the extracranial veins, so the internal jugular, the brachiocephalic, and the azygos veins. And they used a whole bunch of findings, many of which I actually personally never talked to them about this, but these are actually the exact same findings that we look at when we're looking at a venogram. We look at things like decreased outflow, meaning that we inject the dye into the vein, and we kind of expect it to just wash away. Much like if you put a little food coloring in a stream, you would see it for a second or two, then it would wash away. And in many of these patients, what we're seeing and what he saw was just decreased outflow. The dye stayed around in the vein longer than it should have. Then we see reflux, where instead of going down towards the heart, it actually goes back up towards the head. And we also see some pre-stenotic, meaning so dilatation of the vein just before the valve. We look at collateral vessels. We look at narrowing of the vein, literally narrowing of the vein. We see sometimes intraluminal structures. People call them webs or septations or membranes. To be quite honest with you, to many of us, they're all the same thing. It's just stuff, just tissue inside the vein that may be impacting flow of the vein. And in some cases, even a venous occlusion, a complete blockage of the vein. And what Dr. Simka showed was that 96% of patients had an abnormality of at least one vein, and about 4% of patients had a completely normal venogram. And people talk about what's normal, and I'm kind of struck by that. I've spent hours in rooms with people debating what's normal and not normal, and what I found is that as we do more of these venograms, we do find that some veins look more normal than others, and eventually as you do them, you start to develop a diagnosis of, or a picture of a normal vein. And the thing to remember is that there really haven't been many reasons for us to go into the jugular vein prior to this and take pictures So as odd as this may seem, we don't have a big history of understanding what the internal jugular vein really looks like in normal patients. So we're learning that as we go along. And no one wants to be a guinea pig, but the fact is that that's what we are learning. We're learning what the normal picture of a vein looks like. And so what Dr. Simka showed was about 43% of patients had an abnormality of one vein, almost 50% had an abnormality of two veins, and the rest had an abnormality of three different veins. And when he looked at how these findings were distributed, he found that almost 2/3 of patients had a problem in their right internal jugular vein, over 80% had problems on the left side, about 5% had azygous vein problems, and a small percentage of patients had left brachius vein problems. They did not confirm the previous suggestion by Zamboni that there are different distributions of these abnormalities in patients with different types of MS. And what he's really referring to there is some of the early work by Zamboni's group that talked about 4 different types of venographic findings, and he kind of broke them down based on where the stenoses were, and he correlated them with MS subtypes. So he said, well, more patients with relapsing remitting MS had jugular venous disease, and more patients with primary progressive MS had azygous vein disease. And so that got a lot of people talking. And obviously they also talked about some presenting symptoms and correlating the symptoms of MS with certain findings in the veins. We looked at that. We looked at over 300 patients over a 6-month period of time. We looked at patients who had pretty good historical data that was available to us. And just as a very quick aside, Mike referred to it earlier, it's hard to take advantage of all the retrospective data that's potentially out there, because not only are people traveling like you talked about before, but every place is collecting different data. And there's no consistency in how the procedures being performed, no consistency in the data being collected. So it becomes very difficult to look at it, to just say, let's get all the 30,000 patients and see what we can find, because it's also different. In any event, what we found was that about 50% of our patients had relapsing remitting MS, about 30% had secondary progressive, and about 20% had primary progressive. And we looked at it and we broke it down exactly the way Zamboni broke it down. And what we found is that we didn't correlate anything. We found that there's no correlation between the subtype of MS and the findings on venography. And actually, we also looked at the presence or absence of visual symptoms, and we also found that that didn't correlate, which again is frustrating because we're not finding the same answers that Zamboni reported just a few years ago. So it made it pretty clear that it's just not, it made it clear to us that it's not as clear as it's been made out to be. And I think that's a real important take-home point. So finally, just to kind of begin, just one more little topic here on outcomes. There have been some abstracts reported over the past year, not a lot of papers. So I know it's frustrating for us. So there was one paper that was reported at the ISET meeting just recently down in Miami, just almost a little more than a year ago. They looked at 450 patients undergoing endovascular treatment. The study population consisted of only 170 of those patients who completed quality of life questionnaires before and 1 and 3 months after treatment. Also, I'm sure these guys will love this, the EDSS was evaluated before and after treatment by an experienced general practitioner, not a neurologist. And so what they looked at was, for all patients, the EDSS score just basically stayed the same, went from about 4.5 down to 4. They did report some improvement, for the group of patients with an EDSS between 3 and 5, it started at 3.6 and went down to about 2.9, 2.8 there on median score. And for patients that are more severely disabled, that went down from 6.3 only down to a median of 6.3, 6.2, etc. So same with the quality of life scores, based on the questionnaire that they used, you can see that the changes were really not that dramatic in quality of life over time. And so they did still feel that they were able to conclude that short-term improvement in EDSS and quality of life is more apparent in patients with a less significant degree of disability, but there's lots of problems. There really was a very inadequate statistical analysis. There was no neurologic evaluation. Even the tool that they used to report the patient, the outcomes, which is a less desirable way to evaluate patients at all, they didn't even kind of talk about the tool that they used. They just kind of said a generic quality of life questionnaire, and it's hard to know if that's a validated tool, so it's hard to really conclude stuff about that. There's another study that was reported in an abstract form in the Journal of Vascular Surgery. It was a prospective study looking at 205 patients with broken down as followed, and they used a whole bunch of different tools to evaluate patients 6 and 12 months after treatment. They found no significant change in EDSS. They did say that the patients reported clinical benefit of 70%, but the time points were not clear. And what they said was that by 12 months, almost half of the patients had recurrence of all of their symptoms. All right, it's an important point. So I'm not really, to be honest with you, quite sure how they made the leap to this conclusion, but they concluded that CCSVI is related to brain congestion rather than MS. So they felt it wasn't necessarily an MS phenomenon, because that's how they explained the fact that all the tools that we normally evaluate MS patients with, none of them really showed a difference. So he said, well, maybe if none of those showed a difference, maybe none of this is due to MS, it's due to something else, and that was his idea. But again, this study has never made the leap now from being an abstract form to a paper in a peer-reviewed journal, which makes it really hard for us to understand the methodology that was used and the positives and negatives of these studies. We did one study that was just reported, again, just a couple of days ago. It was, again, a retrospective study of over 200 patients. We don't necessarily believe that every study that's done has to answer every question. So we recognize that there are gaps in knowledge, but we looked at about 200 patients who completed a validated questionnaire before and 3 months after they were being treated. And what we found was the mean physical health score, so physical representation of quality of life improved, and same thing with the mean mental health score, that also improved. And when we looked at whether or not this varied with the clinical subtype of MS, what we found was that relapsing remitting patients and primary progressive patients, which was a surprise to us, seemed to respond better than secondary progressive MS patients, and that was a statistically significant finding in both the physical health score and the mental health score. And then we tried to look at just the questions that people are asking us. So we looked at subtype, and then we looked at the years since diagnosis, because everybody says, I've had MS for X number of years, should I still think about having this procedure? And we looked at patients who had MS for less than 5 years, or at least were diagnosed, they might have had it longer, or were diagnosed with MS less than 5 years ago, 5 to 10 years ago, or greater than 10 years ago. And while this was not significant, we did see a trend that kind of implied that if you've had MS for more than 10 years, you're not going to get the same degree of improvement in quality of life. Now, that doesn't speak to any of the more objective ways that we measure patients with MS. It just speaks to a quality of life report from the patient themselves. So, basically what we concluded was that angioplasty can lead to short-term clinical improvement, that it improved less often in secondary progressive patients, and there was a trend to show less improvement in patients with a longer time since diagnosis. And one other study was reported. It was out of the Chicago area. It looked at Dr. Farrell. It was a retrospective study looking at 94 patients broken down as followed. Angioplasty was performed for either reflux or stenosis greater than 50%. And just in the interest of time, just to report that about 54% of patients reported symptomatic improvement, 16.9% reported questionable improvement, about a third reported no improvement. The problem, and he brought it out himself, was that there was not a lot of consistency in this study in how the patient data was collected and what tools were used. So I think there's more work that needs to be done in Chicago before we can kind of take a lot of this too seriously there. So moving forward, I just want to kind of end this by talking about the fact that we are enrolling now in a prospective randomized blinded trial. We are evaluating the effectiveness of angioplasty to treat CCSVI, obviously, in MS patients. We are enrolling 187 patients. All patients are going to undergo venography of the internal jugular vein and the azygos vein. Now, you all know that people are talking about the left renal vein, and the left common iliac vein, and the ascending lumbar vein, all kinds of veins. And our feeling is that, okay, it's interesting, but if we're going to base our design of a trial, because I'm probably going to be talking about the ideal trial, we have to design it based on the information that's on paper. Because people can talk all they want, but until it's on paper, it's really hard to treat it as more than just kind of conversation. And Zamboni's paper is really the only meaningful outcomes paper that's been published so far, and this is what he did. So we're doing what he did. And what we're doing is venography of the internal jugular and azygos veins. And what we're saying is that once we find a treatable abnormality in any of the three veins, we're going to randomize the patients. We're going to open an envelope right there. The patient's going to be sedated, and that envelope is going to say treat or don't treat. So the patient is either going to be in the venography plus angioplasty group or the venography alone group. So it is a randomized blinded trial. It's not blinded to me. It's going to be blinded to the patient and to the evaluating neurologist who's part of the study team. And what we're going to be looking at is a bunch of different endpoints. The primary endpoints are going to be the safety of CCSVI treatment to understand what the risks are to patients. We're also going to be looking as a primary endpoint of the long-term impact of CCSVI treatment on EDSS score. There are some secondary endpoints. The secondary endpoints are going to be including a short-term study of EDSS score. We're going to look at the impact of CCSVI treatment on annualized relapse rates and the changes in MS-related findings on contrast enhanced MRI, plaque burden, number of plaques, etc. This stuff that's typically used to look at this type of treatment in a patient population of MS patients. And then there are several what we'll call additional endpoints that we're looking at. We're looking at the impact of CCSVI treatment on venous pressure measurements. From an interventional standpoint, a lot of people are talking about their pressure differences, so we're going to look at that. We're going to look at how often stents are needed. We're going to look at how often veins clot or restenose after treatment. We're going to look at how CCSVI treatment impacts a timed 25-foot walk. And we're going to look at how it impacts quality of life. So these are all the things that we're going to be looking at in our study. As was discussed, we have our partnership with Saskatchewan and the Yukon Territory. It's actually not with the MS Society, it's with the governments themselves, the provincial governments. And there's also significant interest from our regional MS patients. We have talked about funding. Certainly the Canadian government funding is great. We have donations. We have our SIR Foundation has provided me with a grant to help, and we're certainly seeking other sources of funding for this. But we're working on it, and I think it's a start. It may or may not be. No one is claiming it's the perfect trial, but I think we, like everyone is saying here, we have to do this. We have to do a trial to try and answer some of the questions that everybody has to move forward. So all of us, in conclusion, and many other people, not just the people here, are really committed to providing the clinical service to MS patients based on the positive short-term outcomes that we've seen in the patients we've treated, but we remain really equally committed to participating in really well-designed research studies to answer all these questions to our satisfaction, to your satisfaction, and their satisfaction. And I think it's really important. We're all stakeholders in this, and I think that it's really important to try and work together to figure it out. So thanks.